Bismillahirrahmanirrahim. I am Dr. Sayyid Raza Muhyiddin, member of the visiting faculty of Times Institute, Multan, for MPH classes. This is the second lecture on the healthcare systems, functions, analysis, and policy. In the first lecture, we discussed the definition of healthcare systems and then the different healthcare systems in vogue in different countries and the other factors. And we studied the different healthcare functions. Today we will discuss the health system functions in detail. So as per World Health Report 2000, WHO 2000, this report identifies 4 key functions of the health system. The first was the stewardship, as I told you, and this also refers as governance or oversight. Then that was the important aspect was financing, the budget, the resources needed, economical resources needed for the system. The third one was human and physical resources. As you all know, nothing can be accomplished with the involvement of the personnel, so the human and physical resources are also very important in the function. And then was the organization and management of the service delivery, how these health system facilities is available to the clients or the customers or the patients. So there is a relationship of these all 4 functions, and these are interrelated. The oversight is related with the delivering of services, it is related with the creating resources, it is related with the financing. So stewardship is the oversight, it's above all. Then there are the resources, investments and financing, and collecting, pooling and purchasing, and then the delivering systems, that is the provision of the healthcare systems which are reached to the public. Then now we discuss the different health system functions in detail, and the first is the stewardship. So stewardship are governance, policy and advocacy. This reflects the fact that people entrust both their lives and their resources to the health system. So the government is called upon to play a role of a steward. So it is always the government, because an individual can take care of its health, his or her health, or a community can take care of the community, but on the overall level, the policy and governance is always done by the governments. So they play the role of a steward. So because they have to spend revenues and through their taxes and social insurance, etc., and then the government is the one who made the regulations that govern the operation of health services. Now how the government exercises its powers of stewardship, its functions of stewardship, it is by developing, implementing and enforcing policies that affect the other health system functions. So all the governments have their health system policies which become in vogue from time to time, and the WHO, the World Health Organization, has recommended that the Ministry of Health of any country have a primary role of developing a health sector policy. And what is the aim of the health sector policy is to improving the health system performance and the promotion of health of the people. So all the governments have their own plus and minus factors, levers to exercise the effect of health programs and health outcomes. So What are the government policy levers? So one is the most important is what will be the size of total government health budget. How much percentage of their allocated budget will be spent on health services. So this limit sets the overall limit on what a government can spend. Then there are in the policy, there are the financing mechanisms for funding the healthcare system. For example, the donor support, taxes, users' fees, social insurance contribution, and then the government determines the flexibility for financing healthcare and identifies what are the potential financial barriers that may exist for accessing care. So they can impose fees, their levels, and exemptions. Then are the allocation of the government health budget. So this reflects how the government uses its tax resources, for example, to deliver services, to employ staff, subsidize subsidiary providers, regulate the sector, provide information, and all that. Then is the regulation of civil society organizations. This is also a government policy lever. So this facilitates the constraint that function of the private voluntary organizations, NGOs, and community organizations with regard to service delivery, and the capacity is appropriate for the health services. Then is the political support to raise the awareness for specific health messages and behaviors. So this health promotion policy lever is powerful, which can stigmatize to promote the healthcare situations. Then another lever is adoption of specific health standards and guidelines. So this can also improve the quality of care and then expand the number of providers. Then another lever is regulation of pharmaceuticals. These levers are for the service delivery, financing, and all that. Now, because the recent past we have seen during Corona days, there were allegations on the high government officials of increase the medicine rates, or exporting the different required articles which were to be used in Pakistan, but now that become not non-available, and that led to hue and cry and increase of the rates of that articles. So these regulation of pharmaceuticals can improve medicine quality assurance, number one. These regulations can lead to quality assurance. Although the pharmaceutical companies have their own system of quality assurance, but the government has their own drug testing laboratories, and before a drug is provided to the public, it goes under certain tests in the laboratory so that it can be made effective to the patients. And then can influence this regulation of pharmaceuticals, can influence the ability to bring medicines and supplies into the countries. Already I was discussing. Then are the business regulations, and taxation is also a government policy lever, and it can influence the degree to which the private sector participates in healthcare. For example, import taxes can affect pharmaceutical sales. Business regulations can hamper private providers from setting up practices. Limitations on advertising can limit promotion of branded health products. Then is and you can just take an example of the strong government stewardship in health. There you can give so many examples in other countries which have been successful in controlling different diseases, and still as you see Corona, you see the activities for prevention and behavior changes in different countries. These are all the examples of stewardship. Then in stewardship, there are certain activities that go beyond the health system to influence the main determinants of health. For example, in education, poverty, and environment. The you know the ignorance, or not being educated, or poverty, and the environmental hazards, these are all barriers to health. Now, if someone is so poor, he is not able to listen to your health promotion campaign, he is not able to go to the hospital, he is ignorant of everything. And because the person is just fighting for the food, the first step as the Maslow's hierarchy of needs, you just need food to live. So someone said, a poet said, Sahil Ludhianvi in his famous book Talkhiyan, मुफलिसी हिस्से लताफत को मिटा देती है, भूख आदाब के सांचों में नहीं ढल सकती. When you are poor, you are always thinking of food. You are not thinking of your health, the education of your children and all that. So the stewardship means to alleviation of poverty, to make the people educated, to have the good environment. And then this can also external to the health system, but they can foster or constrain the effectiveness, or mean that like a government can impose a tax, like this corona days when there is the health delivery is minimized and it is compromised, health service delivery. To get the finances, government can impose corona tax or this voluntary collection of this. So this is something beyond the policy. So that is for the broader this is spectrum. Then there are you see the health is a key component of good development policy. In all the development policies announced by the government in annual budget and in the 5-year plans or 10-year plans and off and on, the health is the key component as being the basic right of the every individual, and government is bound to, all the governments are bound to provide good health facilities to the public. And this stewardship is required at all the levels of this national level, the provincial level, regional level, local level, all that levels. And as you see, in Pakistan there exist a district health systems. So a good district health governance, a good provincial governance, and of course the national, because all the levels there are some policy and some stewardship involved. So on all levels there must be optimum or excellent stewardship. Then the second was what we say the financing, which I already told you that money makes the mayor go. So health financing is a key determinant of health system performance in terms of equity, efficiency and quality. So this encompasses resource mobilization, allocation and distribution at all levels, national and local, including how providers are paid. I already in the first lecture told you the definition of providers, the doctors, nurses, paramedics, the institutions. They are all health providers. Now, who will pay them? All this comes under the topic of health financing, and there are different systems of health financing. So, in health finances, there are methods used to mobilize the resources that support basic public health programs, access to basic health services, and health service delivery system. So, we see if, which are the components or what are the components of health financing system. The health financing system consists of payers who are going to pay the finances, providers who are providing the health services, and consumers, the beneficiaries, the people so of the health services, and of course the policies and regulations that govern their behavior. So these are the four big components of health financing system. The simplest example you can say is if the patient pays the provider directly, whereby the consumer and payer are the same person. I go to a doctor's clinic, I take advisement and I pay. Now I am a consumer and a payer. Then is these four components. So consumers of health services are patients. They can pay directly to the provider of healthcare facility, and in return the provider provides him the health services. In other way, the consumer pay taxes and premiums to the government. The government gives them insurance coverage or directly pay to the provider, that is in the institutions the government pays the salaries and all that. And if the payers are the consumers, the government, the insurers, the employers and the donors, these are different variety of payers, and they pay to the provider in the form of fees, budgets, global, and of course that there are claim systems. The patient goes to a hospital, he comes back, he had the service, and then the provider sends the bill to these government, insurers, employers, and get the payment. So this is all the health financing system. Now, what are the sources of health financing? In the developing countries, the health system is financed through a mix of public, private, and donor sources. So there is not a single source. I already, when I was discussing the health systems, the basic concepts, I told you this. It is financed by the public, financed by the private people, and of course there are certain donors. And now, what are the public sources? Whatever public sources are governments that raise funds through taxes, fees, donor grants, and loans. We are fond of taking loans from IMF, Asian Bank, and even the local banks. So that loans contribute to the health budget. And then of course there are donor grants, the UNICEF, WHO, other agencies, they provide us grant from the China for our budgets, which is the health budget is the part of it. Then there are certain fees and taxes and all that government levies. All this contributes to the budget allocation for health department. Now, most government health budgets are historical. Like previous years, you have for health budget, you just increase for few, the inflation rate is added, or in health budget, provided by the government to the health facilities and health or the other health institutions, they have the separate line items. like the government provide budget to the administration in different heads, like in pay and salaries, for electricity, for repair of the hospitals, and all that. And the authorities are bound to spend according to the policy and the separate line arrangements. And then, of course, you can get reappropriation and all that. And then the capital investments, they are found in separate budget that may be paid for through donor grants or loans. And the health development budgets, like for building of a new hospital or of a separate unit in some hospital, in addition to the hospital, that have the part of the development budget, not the main health budget. In decentralized health system like ours in the district health authorities, they are sometimes given the power to allocate the budget in non-capital investments. Up to some level, they can just, allocate the budget, but the main budget is given to the district authorities, and then the DCO and the financial officer of the CEOs of the district, they provide budget to the, the health facilities which are, working under their administrative control, like the district headquarters hospital. All the non-teaching hospitals are in their control. And of course, the provincial governments provide budget to the district health authorities, and the specialized hospitals, teaching hospitals, they get budget directly from the provincial governments, or they generate their own, revenue as well. Then are the private sources. These were the public sources, government sources. Whenever I will use the word public, it means government. So private sources, they include households and employers who pay fees directly to the provider in both public and private sectors. You can well understand, I go to a public hospital and there are certain fees to carry out a CT scan or an X-ray, I pay directly. Or my employer pays, but this is direct pay. Or if I go to a private clinic that are in the panel of my employer, I am not a public servant, I am works in a private factory or a private organization, my organization can pay. They have got certain hospitals and doctors in their panel. So these are the private sources. And the out-of-pocket models, I already told you, is the largest source of health financing in the development countries. Here you have got a large, if you see 4 or 5 public hospitals in a city, you will find hundreds of hospitals on private sector. Then it is an important source of health financing in most developing countries, and you see at this in private expenditure, it is in the form of, mostly in the form of out-of-pocket expenditure by the households. Then there are the users' charges at the point of service. So this is also, as you know, the investigations, and they have the larger fees than the advisements. If one goes for a CT scan or MRI, he has to pay both in the public sector hospital and in the private hospitals. But there are certain exemptions and all that, if you are a government officer, so you are, sometimes charge free for advisement, but you pay for these investigations. Then a user fee is a type of cost sharing for public programs. So this, actually these private clinics, they also form a handsome part of the healthcare system. So there is certain exemption policies. So to promote equity is implementing, the country is implementing user fees. They have exemption policy for certain group of individuals or circumstances, like for disabled, for elderly people, or for the persons having zakat and all that. Then there are certain exemption of fees or exemption for like immunizations under 5, or and certain facilities or some subsidies given to the provided by the government in some conditions. Then there are fee waivers for selected group like civil servants, war veterans in different countries. I told you in the American model there is waiver of fees. Even someone is a veteran or a ex-civil servant, or very poor, so his fees are waived off. Then in private sources there are donors which finance health systems through grant loans and in-kind contributions. Then the donors can also support the health budget directly through loan contributions and through all that. I already told you. Then there are the health insurance systems and mechanisms, which you already know. There are private organizations doing this, and they provide the system. In the developed countries, they have got very good health insurance systems. In certain countries like UK, I already told you the Bismarck method, the mixed method. The main is even if the insurance company is a private one, the fee is paid either by the government or by the employer, or the contribution is made by the private person as well. But all this health care is covered under health insurance systems. All this, now we will study the health care outcomes. Now we see what are the different health system outcomes. And first of all, we will learn what is a health outcome. Health outcomes are changes in health that result from measures or specific healthcare investments or interventions. So health outcomes include preventing death if someone goes to a hospital after a heart attack, if his death is prevented, so through in hospital care, so that is a health outcome. Now, health outcome measures are tools used to assess a patient's current status. Outcome measures may provide a score and interpretation of results and the times risk categorization of the patient. Prior to providing any intervention, an outcome measure provides baseline data. So, what are the health outcome measures? Are the mortality. It measures mortality, these are the number of deaths. Then is the safety of care, you are all aware of the safety of the care. And then are the readmissions. If you are treated in a hospital, you come back but you are not certified, or you are not treated well, you again go, so this is readmission. Then are the patient experiences. What the patient experience inside, you can have the survey of what the patient feels. Then is the effectiveness of care, how effective the health care was. And then is the timeliness of the care, how much time it took. This all the history of the care and cure. Then is the efficient use of the medical imaging which is added. So this was all about health outcome measures. Thank you.